Hello, my name is Lakshmi Ramachandran. I am getting my master's in public health at Harvard Chan, and I'm in the health policy program, concentrating in maternal and child health. And I have the privilege of introducing our first speaker here today. So Dr. Michael Liu is the Senior Associate Dean for Academic, Student, and Faculty Affairs at the Milken Institute School of Public Health at George Washington University. Prior to joining GW, Dr. Liu was the director of the Maternal and Child Health Bureau for the U.S. Department of Health and Human Services from 2012 to 2017. He helped transform key federal programs in maternal and child health and launched major initiatives to reduce maternal, infant, and child mortality in the United States. Previously, Dr. Liu was a professor of obstetrics, gynecology, and public health at UCLA, where his research focused on maternal and child health disparities from a life course perspective. Please join me in welcoming Dr. Liu to the podium.
Okay, hi everyone. Let's pretend we're in a time machine here, okay? And how about let's fast forward to 2050. Okay. You wake up in the morning, you grab your cup of coffee, you open up the newspaper, okay, or the iPad or the hologram or whatever you're going to be like reading the news from at that time. What do you think what headlines about MCH do you think you'll see? How about that we eradicated maternal mortality in the United States? Or that we just fallen farther and farther behind the rest of the world on most standard measures of maternal and child health? Maybe that we finally closed the infant mortality gap, or the gaps in MCH have just gone bigger and bigger. That we turned the tide on childhood obesity, or that for the first time, children's life expectancy is now shorter than their parents. That intergenerational mobility is on the rise, that we're finally delivering on the American dream, that no matter where you're from, the family you're born into, or the color of your skin, in America, every child, every family get a fair shot at reaching their fullest potential. Or that the American dream is becoming out of reach for more and more families. That we reverse global warming, or every summer, we're just ravaged by hurricanes and wildfires and flooding that are devastating the lives and communities all across our nation. Which headlines are we more likely to see in 2050? What will the future of maternal and child health look like? Well, the one main point I want to get across to you today is that what MCH is going to look like in 2050 had everything to do with what we do or fail to do as a society in 2018, especially November 2018, to assure the conditions in which all children and families can be healthy and thriving. So I do want to just take a few minutes today to talk to you about some of the things that we can do in research, in practice, in policy to lead the future of MCH. It's kind of a really appropriate ringtone for this time. All right, so in research, I think if we're really going to move the needle, we're going to have to really change the way we do and fund research in the future. First of all, our research has to become more transdisciplinary, right? And that's because so much of our research today still takes place in silos. Disciplinary silos, institutional silos, disease silos, ages and stages silos. We can accelerate finding solutions to MCH's biggest problems by busting out of these silos and taking a more transdisciplinary, a more integrative approach to research, from neurons to neighborhood, from cells to society, from preconception to old age. Second, our research has to become more translational. Again, that's because much of our research today is still stuck in describing, explaining, and almost admiring problems rather than figuring out what to do about them, right? So for example, we have nearly 3 decades of research describing the critical role that early nutrition plays in developmental origins of health and disease, and yet we still don't have one well-designed study with sufficient follow-up to tell us what works and what doesn't, which leaves an open question as to how to prevent child obesity or adult cardiovascular diseases with early nutrition intervention programs like WIC. Right? So if we're going to move the needle in MCH, we can't get stuck in the discovery phase. We need to fast-track translational research, and not just from bench to bedside, but from bedside to curbside, with an effective feedback loop between evidence-based practice and practice-informed research to accelerate the translation of research into practice, programs, and policies. And our research has to become more precise. Again, that's because much of our research today is still looking in vain for that one-size-fits-all solution. And some of this could be driven by our love affair with randomized controlled trials over the last several decades, right? And you all know that once randomization takes place, you can't change the intervention. You can't adjust, adapt, or enhance the intervention, right? And the way you tell whether an intervention works or not is by looking at effect size average across the entire study population, often without looking at for whom did the intervention work best and for whom not at all. So much like what precision medicine is doing, which is trying to define which drug works best for which patient under what condition, I think in MCH, we gotta start to move toward identifying which intervention works best for which population under what circumstances, moving toward precision MCH. Now, RCTs still has its place, but such level of precision may require a nimbler research platform that allows us to test interventions tailored for individual population risk and can be adjusted, adapted, and enhanced in rapid cycle testing without losing that analytic rigor. So finding ways to promote transdisciplinarity, accelerate translation, and improve precision is how we can lead the future of MCH research. In practice, there's no doubt in my mind that all the scientific advancement, all the technological innovations in the coming decades are going to dramatically transform how we do MCH. And we're already seeing change on the horizon, right? The use of CRISPR for treatment of genetic disorders, the use of robotic limbs to transform disability into superability, the use of biosensors in contact lenses to support non-invasive glucose monitoring in kids with diabetes. But again, if we're going to move the needle in MCH, I think we have to take our practice to the next level. So first, our practice has to become more women-centered, more child-centered, and more family-centered. Okay? So let's just take prenatal care as an example. Okay? I think today prenatal care is still, the way we practice prenatal care, still very much kind of stuck in the early 1990s when I was trained, almost a quarter of a century ago. It's still kind of very much designed around the 15 clinical visits, okay? Which for many low-income women, that means that they have to take unpaid leave from work, arrange childcare and transportation, take multiple buses, wait an hour or two for that 5 to 10 minute visit, which consists largely of a spot urine dip and a blood pressure check, a cursory listen to the baby's heart tone and a totally useless measurement of fundal height, and then just a hurried conversation with the provider who, despite best intentions, just doesn't have the time or the training to talk to you about self-care, let alone addressing your psychosocial concerns or occupational or environmental exposures. Is that really the best that we can do for moms and babies in the 21st century? So what if instead of bringing women to prenatal care, what if we could bring prenatal care home to the women? What if we can collect high-quality information on a more continuous basis with the use of wearable sensors and lab on the chip from the comfort of the woman's own home? And in addition to blood pressure and urine protein, what if we can actually collect things that actually truly matter to pregnancy outcomes and developmental origins of health and disease? Things like stress and sleep, nutrition and physical activities, occupational and environmental exposures. Things are actually really hard to assess during that 5 to 10 minute clinical visit. And what if all of this information could be fed to the cloud, and then with the help of AI and machine learning, we can triage women to getting a call from the health educator, or getting an appointment tomorrow, or getting a home visit tonight. And what if we can crowdsource all these data from thousands and perhaps even millions of anonymized end users to help us develop a better predictive analytics to predict which women are at greater risk, and then tailor our prenatal care to those risks. So moving toward precision prenatal care. And then what if we could just bring design thinking to completely redesign prenatal care around the needs of women and families, and not just the convenience of the doctor or the efficiency of the health system. Secondly, I think we have to make sure that all of the science and technology, all the big data and design thinking, have to be used in ways to advance health equity and not widen disparities. I do worry a lot about that just because so much of the technological innovations right now are driven by market forces, which could actually leave large segments of the MCH population behind who cannot access or afford them. Right? And not that I'm against the profit motive or entrepreneurship, but we have a public health mission here. And our public health mission is to assure access and improve care and outcomes for all women, all families, and not just those who could afford them. And third, we have to prepare our workforce for the future of MCH. Okay. So if in the future our students are going to be called upon to design better systems that work, then they have to be equipped with design thinking and systems thinking. And if in the future they're going to become the chief strategist for community health, then they're going to need to be trained in leadership and management, strategic planning and budgeting, improvement and innovation, collaboration and communication, policy and advocacy. And if in the future they're going to have to be able to keep up with and adapt to a rapidly changing world, then they're going to have to be skilled in critical thinking, problem solving, and lifelong learning. So to paraphrase one of the greatest philosophers in the past century, that we need to prepare our students to where MCH is going to be, and not just where it is or has been. And lastly, and probably most importantly, the future MCH will depend on our ability to bring about real political and policy change. Let's not forget that the biggest gains in MCH in the last 150 years have come from regulation of food and environmental safety, the passage of child labor laws and women's suffrage, and overall improvements in educational attainment, economic opportunities, and social status of girls and women right here in this country and around the world. And that the biggest gains in MCH in the coming decades will come from reversing global warming, cleaning up toxic waste sites, rebuilding our nation's infrastructure, protecting reproductive rights, reducing social inequality, and assuring the social conditions in which all children and families can be healthy and thriving. For too long, MCH has toiled downstream to ameliorate the harms that are caused by decisions made upstream. And as much as we think that we can fix all MCH problems with MCH programs and services, tackling the root causes of some of our biggest problems will require political action and policy change. Okay. So let's not forget that Martha May Elliott didn't just stop at preventing rickets or running the Bureau. Right? She actually drafted much of the language for Title V of the Social Security Act, okay, which shaped the future of MCH for the next 80 years and beyond. Okay. So we now need, over this next decade, a new generation of MCH leaders like Martha May Elliott to rise up into positions of power, right? From the White House to every state house, okay? From the halls of Congress to every city hall, from corporate boardroom to every federal courtroom. We need to infiltrate every decision-making body where key decisions are being made today that truly impact on the health and the lives of our nation's women, children, and families. And that's how we're going to lead the future of MCH, by fighting for MCH in all policies. So let me just close this quote from RFK. Every generation inherits a world it never made. And as it does so, it automatically becomes the trustee of that world for those who come after. In due course, each generation makes its own accounting to its children. And with that, I just want to take this opportunity to honor one of the most respected trustee in our generation for the future of MCH. And Marie, I just want to tell you, on behalf of all of us in MCH, who's been so lucky to have you as our colleague, as our mentor, and as our friend, I just want to thank you for your lifetime of leadership and service to MCH. Thank you.